Good morning, everybody. My name is Larry Brooks. I'm the Chair of Trustees for CANCERactive, and I'm here with my good friend Chris Woollams. But before I start, I just want to clear up a couple of things. I wrote to you all because originally the person that was being interviewed this morning was Jane McClelland, and unfortunately we experienced a lot of unnecessary aggravation, real aggro, not only from the office there, but via Facebook. Vitriolic remarks and what have you, and just not monitored, just not taken down, allowed to be up for 36 hours. And frankly, you know, I have a responsibility to CANCERactive, responsibility to all our members, and I just said enough, and we cancelled Jane. We've left it open so that she can have an interview with Chris about her story and recovery from cancer at a later date. But I then said to Chris, look, you know, we have a show set up to cover off-label drugs. He is more than capable of doing that. As you all know, Chris is a great researcher, respected around the world. And I don't really understand what off-label drugs are. So I said, look, let me ask you the questions and let's do it from there. And then we'll follow up with part 2 by Chris's suggestion at a later date, probably about 6 weeks, with professionals, Dr. Julian Kenyon and Diana Flavin, Professor Diana Flavin, from a professional point of view. But you know, we had a lot of questions in for Jane, and a lot of comments, and a lot of people said how wonderful her book was and that they enjoyed that, how wonderful her story was, but they didn't really understand what metro mapping is and what pathways are, and found the book very difficult to understand. So the simple fact of life is, I said to Chris, you know me, I'm not clinically driven, I'm not medically professional, so can you please keep it to simple language for me, which is what you always do, so that we can all understand. And that, you know, that's an important part. Right, good morning, Chris. How are you doing?
I'm fine, thanks, Larry. How are you? All right?
I'm really, really good. I'm looking forward to this because I just think this is such a fascinating subject. And you know me, I'm not medical. You know, I pick up an awful lot from you, but it's silly things. So could you start first of all, could you tell me what is an off-label drug?
All right, I'm going to keep it all as simple as I possibly can today so we don't confuse anybody, because I get a lot of people come to me for PPs who are confused, okay? There's no question about it. They're very confused about pathways and metro maps and everything else, and they just, you know, tear their hair out. So, okay, what's an off-label drug? Answer, it's been through clinical trials, or supposed to have been through clinical trials, and in America, the FDA would approve it, and in Europe, it's the EMA, the European Medicines Agency. After we've Brexited, I guess it's the MHRA, and it's approved for a specific use. Metformin is approved for diabetes, and you get the indications and conditions on the label, and the dosage and all that sort of stuff. And that's the label, metformin, diabetes, and this is what it does, and here's the conditions and usage, okay?
So do doctors use off-label drugs?
Doctors use off-label drugs almost all the time. For example, let's think, Avastin. Avastin's a chemo drug for EGFR. And they've also noticed it happens to work with macular degeneration. Malarial drug chloroquine, famous from Mr. Trump. Chloroquine is used to treat night cramps, of all things. Then you get things like the steroid dexamethasone. Dexamethasone is used as an anti-inflammatory, but has been found to have certain gut benefits. And then it's taken even further, and people talk about how it can prompt the appetite.
So can they just use it willy-nilly then?
Well, yes, in the USA, pretty well, if a drug is approved, it's approved, and it's down to the doctor to use it, you know, for whatever use he wants to. It's perfectly legal. In Britain, I think it's a little bit of a grayer area, but not too much grayer. So in America, chloroquine is used for malaria, okay? So they use it, as I said, for night cramps. But the problem is, and this is, you know, part one of the problems, I'm sorry, I'm not going to be negative today, but, you know, its side effects are that it can cause heart problems and it actually can cause kidney failure. Well, that's all right if you've got a disease or problem like malaria, which is life-threatening. But would you want those 2 side effects on the label if you were treating night cramps? I don't think so. Then, for example, let's take the whole area of kids. Now, there was a big study done a while back, 8 years ago, on kids. And, for example, chemo. There's no chemo trials, clinical trials with kids. So you're using doctors' best judgment with kids. So they give a certain dosage based on the history of treating kids, which is a little bit riskier than having actual clinical trials. And perhaps chemo is the wrong example, but for example, there are psychoactive drugs. Now, a 7 or 8 year old, I can't remember what age it was, literally jumped out of a window in America, having been given an adult dose of a psychoactive drug. So, you know, there are issues, not just taking things off label, but what dosage do you use with other people when you're using the drug? So there's several big issues here, I think.
Okay, that's America though, but what about Britain?
Well, in Britain, according to the government website, healthcare professionals have more responsibility when they prescribe something off-label than on. But I don't know exactly what that means. They've got more responsibilities, so they've got to take more care. Well, let's think about what I know. Dexamethasone, as I said, is a steroid. It's licensed as an anti-inflammatory. And in my case, as you may remember, I wrote something called Horror Story. I had an Indian lady who was 14 stone in Watford, and she was actually given 3 months to live, and she had cancers all over her. And progressively over the next year, we got her better and better and better. We cut her blood sugar and goodness knows what else. Okay, and she came down from 14 stone to 11 because her daughters persuaded her to go on the rainbow diet. And then some bright spark in a hospital decided that going from 14 stone to 11 stone, she must have an appetite problem, and gave her dexamethasone. And dexamethasone put her blood sugar up from 4.5 to 44 in a week. Now, it's idiocy, because at that point, cancer must have thought it was Christmas. So, you know, if you go off label, you've got to think about this subject you're dealing with. And so it brings a whole load of new rules to the game. So that's my view on the whole thing, really. You have to do whatever you're doing with an off-label drug with doctors, but even then, you've got to be very, very careful.
So if you use something off-label, do they need more than just a clinical trial?
Well, you're never going to get more than a clinical trial, but I mean, it highlights the point. If you've got a clinical trial on this thing being an anti-inflammatory, have you got a clinical trial on it being used for prompting an appetite? You know, have you got a clinical trial on something, chloroquine, being used for night cramps? Because if you had a clinical trial, it would tell you exactly what the side effects were, and then the FDA or someone would weigh up the benefits versus the side effects. So it's a really good question. The answer is, unfortunately, when it comes to the secondary benefit, the off-label use, they've usually got test tubes, they've got observational studies, they've got epidemiology studies. Hardly any of those would even mention the idea of a side effect.
But what about the 1939 Cancer Act then?
Yeah, well, this is the bit that baffles me. We are unique in Britain. We have the 1939 Cancer Act, which basically says you can't describe anything as a cancer treatment and then sell it. And, you know, personally, I can't take 5 vitamins, roll them up into a package and say, come on, who wants to come and buy it? But, you know, people are doing it. And so I'm surprised that the Cancer Act hasn't been brought into play in Britain.
When did you first come across off-label drug use, Chris?
18 years ago, I think would be fair to say, with Catherine, because we knew about a guy called Professor Ben Williams in America, and Professor Ben Williams had been about 50 in 1997-8, and he was a professor of psychology at San Diego, and he beat his glioblastoma, that's what Catherine had, glioblastoma, He beat his glioblastoma by taking the orthodox drugs, but building this package around the outside. It was almost sort of 3 circles. The outside, he did exercise, he did supplements and diet, and he actually put 5 drugs, I think it was, round the outside of his orthodox drugs. He used melatonin, metformin, mebendazole. He used something called Accutane, which is an acne drug, but attacks cancer stem cells. And he knew there was an estrogen factor. This is very interesting because I knew there was one with Catherine. And he used tamoxifen, of all things, the ladies' drug for when they've got breast cancer. And he beat his cancer in 18 months, and the rest is sort of history. He's 70 now and doing very well. Now, also in sort of 2002, 2004, we were looking at swollen prostates, of all things, and they were using 2 anti-estrogen drugs in Australia. They were using finasteride and dutasteride. And they stopped the research after about 1.5 years because although it was working and the prostate sizes were coming down, finasteride seemed to trip prostate cancer. So more people were getting prostate cancer than should have done. But dutasteride, that seemed to be all right. So that was then. What else? In about 2008, we were looking at LDN, low dose naltrexone. Naltrexone is a drug used for addictions and mental problems. It's used at 300 milligrams, sometimes up to 500 milligrams. But low dose, you just use 0.5 milligram, going up to 4.5 milligrams. And it boosts the immune system, and it actually is good for pain. So what they found is, for example, with LDN, you pulse it. And if you take it for 3 days on and then 3 days off, you actually make the immune response even stronger. And that happens for a lot of drugs. And the funny thing was, perhaps the next time I really came across them was I had a chap, I think his name was Lionel, but never mind. And he had prostate cancer, and he had it for 6 years. It went to his bones. And he knew there was a guy in America called Charles Snuffy Myers, who was a scientist who invented 6 drugs and then himself got prostate cancer. And he actually took himself out. He set up the prostate forum in America, and he used to treat prostate cancer using off-label drugs, old drugs. And Lionel went over there, and what was he given? Dutasteride and LDN. So, it's kind of, these things come full circle. So that's a sort of garbled version of what I was using at the time. I mean, I think when I first came to realize this was serious, when I had a lady in about 2008, 2009, who was grade 4, stage 4. And she was going anyway to Professor Angus Dalgleish in London. And he sort of changed a surgery and a chemo round or something. But he put her on Metformin and Atorvastatin. And this was just fascinating to me, because here you have a real life oncologist, one of Britain's top 10 in my opinion, who actually is giving a lady metformin, the diabetes drug. What's it going to do? Cut her blood sugar. What's that going to do? Stop the cancer feeding. That's what he was out to do. And he gave her atorvastatin. Atorvastatin is a lipophilic statin. That some are lipophilic, some are hydrophilic. Lipophilic statins and hydrophilic statins both bring the cholesterol down in your bloodstream. Lipophilic can cross membranes. It can go and do it in your tissues. Okay, so you want lipophilic for cancer. And what do we know? Well, we know that fat helps cancer spread. So what he was doing was actually stopping or reducing the ability of the cancer to spread. So reducing the cancer ability to feed, reducing the cancer's ability to spread. It was fascinating to me because, as you may remember, we used to use berberine right from the outset. Berberine cuts your blood sugar, stops the cancer feeding. We used to use lycopene, and there's good arguments for lycopene. It's not as powerful as atorvastatin, but it's a natural compound from tomatoes. So we used to use that, and there's clinical trials that lycopene can bring down your blood fats too. And it was fascinating to me to, in a funny way, be attacked by the skeptics in 2012 for my views on sugar feeding cancer, when already oncologists in London were doing it. They were actually cutting blood sugar. So all that, you add it together, I mean, that it was a it was a very interesting sort of period for me, but this was all pre-2012.
And so it's not the same drug for each cancer then?
No, I think I'll be adamant about that. Certainly not the same drugs for each cancer. As you know, I don't believe one size fits all. So, prostate cancer is driven by glutamate. It's not driven by sugar. It's driven by glutamate from glutamine and things like that. So it's an alternative fuel, but it's also driven around the body by fat, and more fat. So, you have to take your drug differently for each situation. And for example, there are off-label drugs that can boost your chemotherapy. So it depends. It's not just what cancer have you got, it's what situation are you in, because there's a drug called itraconazole, which I'll come back to. And itraconazole actually seems to give more life to drugs. I'll explain why later on. But, so it's what male or female, what type of cancer, where are you in the cancer process, and so on. So for me, I always ring the changes, I do.
I've got a question here, I'm going to read out from Trish Duffy. She says, I'm currently on the Care Oncology protocol using Metformin, Atorvastatin, Bevendazole, used in rotation with doxycycline, Flarin, 200 milligrams 3 times daily. My GP isn't happy for me to use Flarin in the long term, especially as I have a sensitive stomach. Are there known issues with the long-term use of this anti-inflammatory?
Right, there's several bits to that I'd like to answer. Care Oncology have been using 4 drugs consistently since they started 6 years ago or so. And they're very focused. They're very focused. And I applaud what they do, because they're actually trying to cut the blood sugar and cut the blood cholesterol and stop the cancer feeding and affect the immune system and so on. They're focused on this whole area. Okay. Flaring was the question. Sometimes they use flaring. Flaring is an NSAID. It's like a glorified aspirin. In fact, in this case, it's a lipid version of ibuprofen. Now, as you know, I am very, very interested in the microbiome. And we know NSAIDs are really bad on damaging the gut lining. They're really bad on the microbiome. And while there's some occasions when they can help, by and large, they damage it. I wouldn't, if I had any problems with the gut, I wouldn't use an NSAID for more than 2 minutes. I really wouldn't. I probably wouldn't even use it. And so I think her doctor is completely right. I wouldn't be using it in the long term, flaring, and I don't think if I had a gut problem, I'd be even using it at all.
Wow. Okay.
Well, I mean, it highlights the point I'm making. Flaring, is an ibuprofen, and it's probably got conditions and everything else that you take, but it must have somewhere written the problems with it. And if you go off label to any degree, you've got to know what those problems could do. And you've got to know all about the patient. As you know, I get people, it's probably a pain in the bum, but I get people to fill in a form that's about 5 pages long. And I want to know what their other conditions is. The number of people who've got a thyroid problem, for example, or Hashimoto's or chronic fatigue syndrome, whatever, or went to Egypt or Mexico and picked up a parasite. It tells me loads about them and what else is going on in their body. And, I'm only using supplements, for goodness sake. I'm not using a drug that can cause all sorts of side effects. So I think it's really, really important that you know all about your patient and all about what the drug can do and what its side effects are before you use it.
Okay, can we just go back a minute, because I mentioned in a question there, who are Care Oncology?
Okay, Care Oncology are oncologists. I applaud them for what they're doing. They opened in Harley Street, I think in 2014, and they've now got a branch in America. And as I said, they are totally focused. They're focused on glucose restriction, cholesterol restriction, glycolysis restriction, and basically the metabolism of cancer cells, the metabolism of the immune system. They're focused in this area. Yeah, they got things like mebendazole that attack cancer cells, but that's what they're focused on. And it's a major plank, as you know. I mean, when Catherine got her brain tumor, I remember walking into Beanie. I wasn't allowed to see Beanie. He was the oncologist in charge of Catherine because I was trouble. And he sort of had his little mate with him. And I'm probably being rude. I don't mean to be rude. But he said to me, "You got any questions?" Sort of backing off. And I said, "Well, actually I do. I mean, Catherine's just had a brain tumor operation. And I'm puzzled." I said, "Why do you let her eat ice cream every day and Ribena?" And he knew what I meant straight away. And he turned to his mate and they laughed at me. And they said, "Oh, Chris thinks that if you could stop glycolysis, you could stop a brain tumor." Yep. I'm a biochemist. I mean, A-level biologists do it. Glycolysis, cancer. Okay. And this is what Care Oncology do. They're trying to inhibit glycolysis.
And do they use the same 4 drugs for everybody?
Well, yes, because they're doing something very specific, you know, and so they will do it with brain tumors, they'll do it with colorectal cancer and so on. And as I said, if I wanted to restrict glucose and so restrict glycolysis, that's what I would do. If I wanted to stop a cancer spreading, we know when cancer spread, right, we know the primary cancer, for example, burns sugar. I don't care what cancer research say, I don't care what nurses say, dietitians in hospitals. As you know, we have got this article called 20 links between sugar and cancer. And now, because I've updated it regularly when new researchers come in, I think 18 of the top 20 links are all top hospitals, top professors. Just, you can't argue with it, Larry. You know, cancers are fed by sugar, and they have 14 times the insulin receptor sites to suck it in, suck it on board. So that's the primary. But once the cancer cell gets into the lymph, it switches and it starts to burn fatty acids. And we know that it picks up a little backpack of fat, and now it can go off around the body to the lungs or whatever. We know it goes around in a fat bubble, so the immune system can't see it. And finally, we also know that almost every cancer, people on a low-fat diet survive longer. And there's a big study on cancer overall, and it shows that people with the highest levels of blood fat get more metastasis and survive least. So this is what Care Oncology are trying to do. They're trying to tackle those things. And metformin and atorvastatin, metformin cuts your blood sugar. It has some effects in research, not very many, not much research against cancer and its mitochondria, power stations. And it also affects the liver and seems to pull blood fats down. But atorvastatin's the one, and that actually does reduce blood fats and I think greatly restrict the ability of this thing to spread.
So is there good research on these?
I think this is the $64,000 question. Yes and no. Now, just for everybody's knowledge, we have an article on the website, which is a sort of kiddie's guide to how to build an off-label drug protocol. And it's got them all listed. But more than that, I have looked at Care Oncology, I've written them up, and only recently it went out, actually today, last Monday, I think, in the e-news. Now, on top of it, we actually have written up metformin, atorvastatin, and so on. They're all there. And in order to do this program, I added to them. I went right through what Care Oncology said, went right around the web, trying to find out research and so on. And the problem is, if you take something like metformin, you get observational studies. So diabetics who are on metformin survive longer than diabetics who are not on metformin. So the conclusion, therefore, is metformin's doing something, and it must be to do with sugar that make people live longer. It's an observational study. Doesn't tell you anything about side effects or anything like that. And then you get epidemiology studies. And epidemiology studies aren't quite as definitive. So, you know, this population did this and that happened, but this population did this and this happened. You also get a lot of test tube studies, Petri dishes, we used to call them in biochemistry, and you can drop things in there and something happens or something doesn't happen. And those are the sort of studies, for example, when we do them on curcumin or berberine or vitamin C, the oncologists poo-poo. Well, if I said to you on metformin, there's probably 2, 3, 4, 5 small clinical studies, clinical trial studies, at best, phase 2 of a clinical trial since 2015. But almost all the evidence is coming from observational studies and so on, and epidemiology studies. You'd understand the picture. So the bottom line is we could do with some real clinical trials on metformin and Atorvastatin. And Care Oncology are actually doing one. I mean, they've done this study so far with these 4 drugs with brain tumors, and the average life expectancy with a GBM is 15 months. And they've got people to have an average life expectancy of 30 months. But they started in 2014, so they've only been going 6 years, and you know, they've only had time to kind of measure brain tumors, because brain tumors are really damaging. Now, when it comes to breast cancer, ovarian, and so on, they've still got people who are alive, kicking and well, so they haven't quite got the figures. And I think on the American site, there's something kind of a bit woolly about. We're doing really well on other cancers too. So that's the picture. They are doing a clinical trial. We'll know more about their 4 drugs at the end of the day. I mean, whenever they declare the results.
And who sent people there?
Yeah. I sent several people early on to them. Yes, I sent some brain tumors. Yes, I sent some colorectal cancers. I sent Zoe, who we're going to be interviewing in a few weeks' time. And Zoe was breast cancer, 6 lymph nodes, going to do the usual FECT. And they were very helpful because they're oncologists. They've got, you know, a guy from Barts, they've got a guy from UCH, they've got a guy from Royal Marsden at the moment. And so they know what they're talking about. They were very helpful as oncologists to her. She did the Care Oncology protocol around the outside, but she did, as you know, lots of things. She did hyperbaric oxygen and supplements and dum. So we built a whole package for her. And she's coming along in 4 weeks' time to tell us, basically, here she is 6, 7 years on and hasn't got a trace in her body. So we have sent people there. Sometimes, and I'm not being rude to Care Oncology, as I said, they do what they do. We need more. We need more from off-label drugs. But anyway, I think cancer patients need more than they do. They need this whole thing. I call it shutting the doors. And I think you need to shut the doors. And there's probably anything between 6 and 12 doors, depending on what cancer you've got, what stage you're at, and so on. And you actually have to shut the doors, because if you leave a door slightly ajar, then cancer just runs through it and spreads. So, you know, we'll talk about that, I'm sure.
There's a question from a lady in Hong Kong called Audrey, who says, I'm aware that some cancer patients have successfully stopped their cancer growing using off-label drugs. Is this the case for most patients? Is it cancer type dependent, age dependent, sex dependent, etc.?
Okay. Yes, it is for most patients. Now, what do I mean by most? North of 50%. Can I give you a figure? No. But fundamentally, even in the program I would build, I'm using berberine, lycopene, or I'm using berberine. And yes, if we needed to use atorvastatin, I mean, I've had a guy in Ireland recently and a lady in Ascot, both of whom had 9.8 cholesterol. You've got to get it down. You need 3.8, something like that. We just had research from on pancreatic cancer, but I think it could have been any cancer, where, you know, cancer cells start to hoover up cholesterol. So you see what the problem is. So this part, stopping the cancer feeding, stopping the cancer spreading, and maybe attacking it a bit. Yes, it's very important. And the answer to the question is yes, I think it will have an effect for most patients, but I think there's loads of other things you need to do. So we would look at their oxygen levels, for example. We would look at their vitamin D levels. You know, I've just done a load of work on vitamin D, and everything I've said for the last 18 years has turned out to be true. Thank you, COVID. I mean, in a funny way. And then we'll cut their blood sugar, and then we'll worry about their blood fats. We also use actually an off-label drug. We use something called loratadine. You could have cimetidine, they're antihistamines. What's that about? Well, actually cancer cells have 6 times the histamine receptors on them as a normal cell. And they pull histamines in, and it makes the cancer cell swollen and sticky. And now it can go off around the body and either stick to its mates or stick to the lungs or stick to the liver or whatever and spread. Now there's very good research from the Karolinska, Johns Hopkins and whatever that shows that people who take cimetidine or loratadine, depends on the cancer, actually survive twice as long with colorectal cancer or 30% longer with breast cancer. So you kind of have to pick your patient. So loratadine, we might do that. But the big issue for me would be tending to someone's gut and making sure they don't have yeast or making sure they don't have parasites and things like that. And then you get this other big area, which is the whole way cancer can spread. So you've got a minor way it can spread. You might not say it's minor, but through fat. And you can have high blood fats because of hereditary. You can have high blood fats because you eat badly. You can have high blood fats because you've lost gut bacteria. So gut bacteria, some gut bacteria make short chain esters that block cholesterol being formed in the body. But also cancer itself can make you have higher blood fats. I won't bore you with how, but it can make you have higher blood fats. So that's one way. But the second way, a big way, is you've got this whole area of inflammation in the body, stress in the body. And stress in the body is a really big issue to tackle, which of course Care Oncology don't even bother, well, they don't claim to go there, okay? But we would. And you can get inflammation in the body because you've got the wrong gut bacteria, parasites, whatever, bad guys. But also there is a hormone called an icosanoid. Okay, now let me explain. There's an enzyme in every cell of your body called COX-2. And COX-2, if you turn it on, makes about 130 localized hormones called icosanoids. There's 6 of them. They're called prostaglandins, and they cause arthritis in your body. Okay, so these are very, very inflammatory hormones. So you can have the wrong gut bacteria that can give you inflammation, but you also can turn on COX-2. What can turn on COX-2 is stress. So you get stress, you make cortisol, you make adrenaline, they both turn on COX-2 and you get stress all over your body. Cancer sees this. So cancer actually hits your adrenals and you make more cortisol and more adrenaline. So you've got to tackle those two because they are now going to turn on COX-2 and make you highly inflamed, stressed throughout your body. Okay, now let's just stop for a second. We're on the subject of off-label drugs. There was a professor in MD Anderson about 4 or 5 years ago. He specializes in ovarian, and he happened to notice of his grade 4, stage 4 patients with ovarian cancer, those that happened to take a beta blocker, propranolol, survived 4 years longer than those who didn't happen to take it. This is pure by coincidence. This is what you mean by an observational study, right? So he's looking into propranolol. Well, propranolol, if you go to your doctor and say, oh, I feel stressed and I have anxiety, those 2 words, he'll give you propranolol, almost certainly. And what's really interesting about beta blockers is there are 3 for the heart, but there are about another 14 for the body. And if you look at their effects with cancer, and you look down the list, you've got 001, 001, 017, and that's propranolol. It's got effects with lots of different cancers. So propranolol is an off-label drug. Now, historically, we've used ashwagandha. Ashwagandha, Ayurvedic herb, exactly the same job. Probably not as strong or anything like that, but that's what we do. So, long-winded answer, no apologies for that. She's aware that some cancer patients have stopped they're cancer feeding. Yep, I think perhaps 2/3 for a period of time. It could be a year, it could be 2 years, whatever. My personal view is a great thing to do. You should be stopping cancer feeding and spread, but there's loads of other doors you have to shut as well.
Such as?
All right, I would always want to kill parasites and gut bacteria. Okay, bad gut bacteria and yeast in particular. So, for example, I mean, this is a good story. This, a lot of, when people take chemo, it puts their white cells down. It puts their gut bacteria down. And every mouthful of food you eat brings yeast into your body. And if your good guys aren't there, you have a problem, because at night time, your good guys eat 2.2 pounds of yeast. So now you've got a yeast problem, right? They take over your gut, make you feel a bit swollen when you're having chemo. They get through into the bloodstream, and then they can create havoc because they will colonize areas of your body, and they're anaerobes. Now, I mentioned itraconazole earlier on. Fascinating, this, because we always cut people's yeasts, and we do it with oregano oil. We might cut their bad bacteria with something like artemisinin. We might kill parasites with para-free. You know, we've got the little packages depending what this lady's filled in oil for, or this man's filled in oil for. With pancreatic cancer, like others, we've always killed the yeast. Cancer bodies almost always got loads of yeast all over the place. Well, they've just found about pancreatic cancer that gum disease is linked with pancreatic cancer. They've just found out that those bugs from gum disease go into the gut. They just found there's a 1,000-fold rush of bugs all around the pancreas just before you get pancreatic cancer. And they found that there is a yeast. Do you know what? I can't remember the name, but it's not your classic Candida albicans. But they found there's a yeast that kind of joins the party. And so they took pancreatic healthy cells and dropped the yeast in, thinking it would cause cancer. It didn't. But then they noticed on the surface of the yeast, there was this carbohydrate compound, MBL. And they dropped that in, bang, pancreatic cancer. And lo and behold, itraconazole works really well with pancreatic cancer. Guess what itraconizole's main purpose in life is? It's a yeast killer. So here you have a drug, it's a yeast killer, that now, if you go to my website or our website and you look at itraconazole, you'll see it works really well with 6 cancers, and it makes drugs work longer. Well, okay, we don't know how it makes the drugs work longer. What if it's killing the yeasts in the body? That would help make the drugs work longer. So yes, I kill parasites and bad bacteria. Yes, we get people's oxygen up and we make sure it's 99. Yes, we get the vitamin D up. I've just written an article saying 125, because it's always measured in scientific journals in ng per mil, which is 50. I believe it should be. And in hospitals, sometimes they measure it in n moles per litre, and the nurse comes along and goes, oh, you're 60. You know, that's way too high. No, unfortunately not. N moles per litre is 2.5 times ng per mil. I want you to be in 50 or 125. We boost the immune response. You've got to boost the immune response. That's what vitamin D does. One of the biggest things for boosting the immune response. But we also do it with soluble fiber, because soluble fiber actually boosts the good bacteria in the gut, and soluble fiber, people who have the highest consumption of soluble fiber have the best immune systems. And we stop COX-2 spread, because COX-2 spreads with cortisol and adrenaline, but also with insulin. So we do that. So we do lots of things. That's how packages beat cancer. Care Oncology are doing a bit of it, and they're doing it really well.
Do you use other off-label drugs? In fact, do you use any?
Personally, I don't use any off-label drugs. I might suggest someone takes a look at loratadine. But if off-label drugs like propranolol or dipyridamole or something like that are interesting for a particular patient, I would talk about them. I quite often send people to Care Oncology for their starter pack, because that's what I think Care Oncology are doing. They're giving you the starter pack, and it's going to work quite quickly. But frankly, I would send people to a doctor like Julian Kenyon in the Dove, or somebody else who knows their stuff on these drugs, because I keep saying, you know, don't muck about with them. You can't. So, but what fascinates me is when you discover what these drugs do and that people are going to use them in an off-label context against cancer, we've always got a natural compound. So, for example, dipyridamole works really well with breast cancer and other things. What does dipyridamole do? It actually is a drug to cut your platelets. And there's lots of research, goes right back, 30 years, cuts your platelets. Well, we give people turmeric or curcumin, and we've actually gone up as high as 8 grams of turmeric for a couple of ladies with oxygen, and they've beaten their cancer. But that's a different story. When you give people turmeric, and it's totally random, some people, their platelets take a dive. And the nurse goes, oh dear, well, come off that turmeric because it's really bad. If your platelets take a dive, you could bleed to death. Well, you could in extreme circumstance. But actually what no one seems to know in hospitals is their biochemistry. And if you reduce the platelets, you're actually reducing the cancer's ability to grow a blood supply, to grow, and to spread. So that's how dipyridamole works, but turmeric would do it. Itraconazole, I've just told you, is a fungal, antifungal, and it does things. Well, we use oregano oil, but oregano oil is not going to extend the life of your drug, I don't think, too far. Although we do have situations like that. I've talked about loratadine, cimetidine. What else? We've got what's really interesting at the moment is the number of patients in America using fenbendazole. Okay, so let's talk about the 2 other Care Oncology drugs, mebendazole and doxycycline. Mebendazole is a human, licensed for humans, parasite killer. And it attacks tubulin, which is in parasites because they're full of microtubules. And so it destroys, damages the microtubules and kills the parasite. Well, guess what? Cancer cells have that too. They have microtubules and tubulin. So you use mebendazole, you can damage the cancer cell. There is a drug called vincristine. It's used, funny enough, with brain tumors. Mebendazole has research with brain tumors and quite good research with brain tumors. Johns Hopkins again. I don't think mebendazole's got too much else, too many other studies on it. And I've looked, I can promise you. Fenbendazole is the interesting one. Fenbendazole is an animal parasite killer. Does much the same job as mebendazole, loads more studies, and it's being used with prostate cancer, lung cancer, all sorts of things. Now, I have no idea, because I'm not qualified to this, I'm not a doctor, whether fenbendazole is stronger than mebendazole, but fenbendazole is an animal parasite killer. It's called a Panacur. It's used for dogs, for example. You take it 3 days on, 4 days off. There's a chap called Joe Tippins in America who wiped out his grade 4, stage 4 lung cancer in 3 months. He took fenbendazole with vitamin E succinate, which we know attacks cancer cells, and vitamin D. Yep, well, we know that's totally essential for your immune system, and he took it with CBD. So he's got a little protocol. So do we use fenbendazole? Well, I suppose indirectly we do, because we've got lots of people in America using it at the moment. But there are, you see, let's talk about doxycycline. If we've got time, I don't know, you tell me. Doxycycline is the 4th drug. I'm not madly keen on doxycycline. And the reason I'm not madly keen on doxycycline is because doxycycline is an antibiotic. Now, doctors will say, it's been around for 30 years, it's perfectly safe, we know what it does, we know what it... Yes, but it's perfectly safe in the context of an antibiotic. And I don't like antibiotics because what I'm usually doing with my patients is building up their gut, not damaging it. Okay, so when I send people to Care Oncology, by and large, they're already on drugs. So their gut bacteria are already damaged. So they're not going to get much worse. So that's point number one. But point two, we know with doxycycline that doxycycline has an effect against cancer cells, but in particular against cancer stem cells. And we also know there's two others. So Ben Williams used Accutane. We know there's another one called niclosamide. If you've got a damaged P53 gene, you also kill lots of 60% of the tumor. So there are other drugs, not just doxycycline. Now, doxycycline has got limited research until Professor Lisanti came along. Professor Lisanti is an American working in Salford in Manchester, and he did a study where he, petri dishes, he took doxycycline at one level, and he took cancer stem cells. Now, cancer stem cells are the heart of a cancer tumor. So you can knock a cancer tumor back 70%, but if you've got cancer stem cells left, it can always regrow. They're very big levels in pancreatic cancer, pretty big levels in prostate cancer, and it comes down for other cancers. Brain tumors have got cancer stem cells. So almost everything, multiple myeloma, breast cancer. So cancer stem cells, what he did was he gave a dose of doxycycline. Now, cancer stem cells have mitochondria, power stations. Would you believe the mitochondria in cancer stem cells date back millions of years, or a couple of million years? They are the earliest bacteria we took on board in whatever form we were in a million years ago. And so they're bacteria, so they get killed by antibiotics. So give them doxycycline, you kill half of them. Then Lisanti took a month off. He gave them 50% more doxycycline and killed half of the remainder. And then he gave them a month off, and then he did it again, a much, much higher dose. And what he said was, and this is very important, at the end of those 3 doses, he had doxycycline resistant cancer stem cells. And he then urged the use of 8 compounds, one of which was chloroquine, ironically, but the other one was berberine, exactly what we use. And he also said you could use intravenous vitamin C. So I come back a little yard. There's not a lot of research on doxycycline, sorry. We do know it attacks cancer stem cells, big tick. But I believe you've got to use berberine at the end of it, or intravenous vitamin C, because I've looked at the research. Now, I'm sure Care Oncology have. They don't use it that way, so there must be a reason why they're using it a different way. But of the 3, I'm not madly happy using doxycycline. I'm not madly happy using Accutane because it's got a very big side effect. It affects the liver. And it depends how long you're going to use it for. Niclosamide would be more interesting for me. So that's a kind of quick rundown on off-label drugs from us. We probably have seen our patients use 15 to 20 different ones. It's all on the website. It's all there in how to build yourself an off-label drug protocol. It's all there, listed out, and then the links to each individual one with our research.
So if I want to find out, people want to find out quality information on these drugs, they should go to
CANCERactive website. It's all there. I find it interesting. Every time I do a Chris Woollams e-news, okay, I always get 5 people who say, how do I find out so-and-so and so-and-so? And the answer is, look on our website. We've got 4,000 pages, Larry, 4,000 pages. And, you know, we update, I would say the top 700 regularly. So it's all there. All these drugs are there. And the research, if there's more research I don't know about, anybody's welcome to write to me and say you've got something wrong, or, you know, here's some more research.
There's a lady called Lynn Brand has a question. It's a good one. Can you please speak a little about melatonin, its benefits and the dose to take? You advised me to take 20 milligrams in my PP a year ago, but maybe new research suggests much higher doses. And where can we get high dose melatonin from?
Well, I think there's an interesting issue here, because you talked about new research. Send it to me. Send it to me. Now, let me tell you about melatonin. If you go to the doctor and ask about melatonin, he will tell you it's the sleeping drug. He's got much better drugs than that. And he can only prescribe in Europe or Australia, he can only prescribe 2 to 3 milligrams. In America, you can buy it in the supermarket. Canada, you can buy it in the supermarket. Okay. Now, melatonin is made by the pineal gland about 45 minutes after you go to sleep. Does that make it the sleeping drug? No, it means you make it after you go to sleep. It is the biggest antioxidant we make by far. It's not just big in terms of volume. It works like that. It's unbelievable. It works really fast at quenching free radicals and so on in the body. It's also very, 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 very anti-inflammatory. So you add those two together, it's why sleep is so healing. So it should actually be called the healing drug, not the sleeping drug, because there's not a lot of evidence it's a sleeping drug. We know that it's very good against estrogens. We know that from the science. We know that people have disturbed sleep patterns, long-haul air hostesses, night workers, whatever, get more breast cancer, prostate cancer, estrogen-driven, and so on. We also know it's got 5 actions against cancer cells. Over the last 5 years, more and more research done, and the figures are 20 milligrams. Sloan Kettering talk about it helping with chemotherapy. The National Cancer Institute do. So, you know, it's in America, there's this momentum building up. I did a presentation with Professor Russell Rita. He comes from San Antonio, Texas. I can't do the accent, you probably could. And he is UCLA's professor, and he's an expert in melatonin. He said everybody with cancer should be taking melatonin, not just estrogen driven, but everybody with cancer, especially if they were having chemo, because of these 5 ways it attacks cancer cells. And so I'm all for it, no question about it, especially if people are having chemo. Now, there was a YouTube doctor talking about how high dose melatonin was the thing to be looking at, where they're giving 60 milligrams 3 times a day to people during the day, and people don't go to sleep because melatonin actually does have an effect with sleep. Melatonin is produced by tryptophan, which makes serotonin, which makes melatonin. And equally, melatonin's got this long chain reaction in the body. And yes, sleep is a part of the end product. But these people don't go to sleep, basically, if they get 3 lots of 60. And the doctor in question cited Russell Rita. But as of yesterday, when I had a good look, I could not find any research on high dose melatonin anywhere. Not something I would believe. So I think it comes under the heading of, yep, all the logic's there, but do you know what we could do with some good research? I think this actually covers, that statement covers the whole of the off-label drug area. I mean, you know, that's what people would say about berberine or vitamin C or curcumin or whatever, and milk thistle, you name it. We could do with some really good research. And oncologists need to start, applying the same critique, the standards of critique to their own drugs here before we get too excited.
There's a lady called Edwina Jenkins who sent a question in. It was really more for Jane, but I mean, as you know, you're mentioned in Jane's book, and you mentioned that advanced cancers may need more to remedy them than the suggested pathways described. Do you have any particular recommendations for killing a large 11 by 8 by 4 centimeter rare MPNST tumor? MPNSTs are notoriously unresponsive to chemotherapy, and I can't have surgery. And before you answer, could you just tell me what is an MPNST?
All right. Well, as far as I know, again, I'm not a doctor. It's a sarcoma. It's in the nerve sheath. Okay. Now, we just had Tabs Headington on the show, and Tabs had a sarcoma in the groin. And sarcomas are notorious because chemo doesn't work very well with them, and they're quite rare, and doctors throw their hands up a little bit and like, what the hell do we do? So by and large, chemo is not in the game. So she's ruled out for surgery. There are some issues here. Pathways first. Okay. I'd like to comment on pathways. Now, I know Jane, right, number one, Jane, brilliant, absolutely brilliant. As you know, I did actually at some point talk to her about her cancer a long time ago. I think the story of how Jane beat her cancer, fantastic. Everybody needs to know because, she was diagnosed in the end with terminal grade 4, stage 4 leukemia, and she beat it. So everybody, please know there is no such thing as terminal cancer. And Jane does a great job of that. I think when she comes on to explain it, it's about 20-30% of people really get it. And they are looking at these pathways and everything else. Another 2/3 of people, as you pointed out at the start, just don't get it. And it all gets too complicated. They get all kind of like, frenetic. I get people all the time, what can I do about this? And calm down, because actually stress is in the driver of cancer. So pathways, for me, is a big issue. And it's an issue for several reasons. I know all about the Metformin and pathways. As far as I'm concerned, I'm sure there are people out there who would disagree with me. I don't mind that. But pathways are where it all gets too complicated. And I'm an epigeneticist, so I don't believe you've got a KRAS blockage, mutation. You haven't got a sequence change. What I believe is you've got external factors blocking this gene from sending out its message. I don't think you've got a mutation, you're not doomed, etc., etc. And so I believe that there are lots of factors, everything from gut microbiome to environmental factors, whatever you have to deal with. Oncologists themselves don't always have a drug to tackle a pathway. And Care Oncology never went out to tackle pathways. And I just come back to it. That's not what I'm trying to do. And I think you could drive yourself loony worrying about your pathways. I just say to people, block all the doors. Block all the doors from stress to insulin to oxygen to vitamin D and so on. And yes, this bit that Care Oncology do, stop it feeding, stop it spreading, really, really important. And if you can use things in your plan that attack the cancer, great. And as you know, when I build programs, I like to use things that attack in 3 or 4 ways. So she's asked a specific question here, and she uses berberine, I think. And, we know it blocks OXPHOS and other mTOR and things like that. We know that. But what I would say is it cuts fasting blood sugar better than metformin. It attacks the energy production system. And we've got good research on that, probably better than metformin. It kills microbes and it's highly anti-inflammatory. Whereas metformin cuts your blood sugar, not quite as well, I think, as berberine. Does have a little bit of research on attacking cancer cells, and it's certainly not anti-inflammatory. So, atorvastatin, we know, is very good at getting inside things like the nerve sheath and reducing the fats in those areas. So if she's stuck, I might ring the changes between metformin and berberine, and I would probably use atorvastatin. But in her case, I wouldn't be worried about pathways. I would just be worried much more that I was doing the package.
You say that programs kill cancer cells.
Yeah, programs kill cancer. For example, when we deal with sarcoma, we actually might use atorvastatin, or might say go and see someone about atorvastatin. We've actually used in the past cannabis really well. So we use LDN. I talked about LDN earlier on, low dose naltrexone, and we use it 3 days on and 3 days off. But we actually, and in fact, I rang these doctors in Scotland. You go to our website, read about LDN. It's in the phone number, it's in our website. You ring the doctors in Scotland, and if you qualify, they'll get you to fill a form in. They would prescribe LDN. Angus Dalgleish, his Dr. Liu in St George's has actually shown that if you pulse it 3 days on, 3 days off, you get a much bigger boost in the immune system and you deal with pain relief. Well, so does cannabis. So I rang Scotland because I had a patient who wanted to use cannabis as well. And basically, we've worked out with them and others that you should take cannabis under the tongue at night time, and you should do CBD by day, then you don't go around kissing policemen or something. And you do that, and you take LDN 3 days on, 3 days off. It boosts the immune system like crazy, and it's a very good way of just suddenly giving yourself a shot of immunity against your cancer. So, you know, with Tabs Headington, she did proton beam. Well, yeah, you need something that kills this. And do I want to turn to a drug? No, I don't think the chemo works by and large. Do I want to rely on off-label? No, I don't think you can. I think you'd have to build a package. Proton beam, if you can get hold of it, in Tabs's case, is not going to kill anything before this groin tumor and not going to damage anything afterwards. So that, you know, again, it comes down to who is it, what cancer they got, where is it, and so on. So programs are vitally important as far as I'm concerned, because I think I agree with several top oncologists in America who believe it's naive to believe that any one drug, Dr. Henry Friedman, I think we quoted on our site, who's a brain tumor expert, it's naive to believe that any one drug could beat a cancer. It's naive, in my opinion, to believe any one thing could beat cancer. You build packages, and if you're going to try metformin, melatonin, mebendazole, doxycycline, atorvastatin on top of carboplatin and what have you, fine. I have no problem with that. That may be a drug package of orthodox plus Care Oncologies that will do the trick. But for me, number one, I want them to enhance each other, and I want them to be no crashes into each other. And number two, I wouldn't leave it there. I want your vitamin D up, because we know drugs reduce your vitamin D. I want your oxygen up. I want other things to be taking place.
So are there any drugs that you wouldn't put with the Care Oncology package?
Immunotherapy. I, anyway, like to give immunotherapy its best shot. So we know that immunotherapy works in about 17% of cases, doesn't work in about 17% of cases, and then there's a load of people in the middle who get 1, 2, 3, 12 extra months. And immunotherapy works in conjunction with your T cells. This is fascinating, because doctors, they talk about immunotherapy being a fourth plank for doctors. And so you've got surgery, chemotherapy, radiotherapy, and now immunotherapy. But doctors don't use it like that. They just see it as another drug. Okay, so they've still got 3 planks. But there is research from Chicago and other places, Chicago Medical School and other places, showing that if you take probiotics, you improve immunotherapy. If you eat soluble fiber diet, you improve your immunotherapy. What are you doing if you do those 2 things? Well, probiotics and high soluble fiber diet both put up the good bacteria, and they put up your immune system. How do they do that? They make you make more T cells. And T cells are crucial to making immunotherapy work better. Drugs, other drugs, tend to put your gut bacteria and your T cells right down. There's research from Lille, there's research from Chicago Medical School saying this. So I wouldn't use anything from me that might conflict with immunotherapy, and I would rule out Care Oncology. And I'm sure Raphael and his team are going to send me some research saying that actually their program works really well with immunotherapy, but I would want you to have the best bunch of T cells you could possibly have at the time you're having immunotherapy. I've had people on immunotherapy literally beat their cancer. A couple of years, Keytruda, pembrolizumab, cancer's gone.
Wow. Okay, Wendy Howell in Hong Kong. It just amazes me how far-reaching this program is. Since 2018, I've been concentrating on reducing and stopping the glucose pathways. However, a recent rise in circulating tumor cells and the appearance of circulating stem cells, where previously I had none, makes me suspect the cancer may have transferred its fuel from glucose to glutamine. I'm working towards covering these pathways together with fatty acids and redouble my efforts on the glucose to make sure all pathways are blocked. Not sure what the question is there, but.
Okay. All right. I think this is kind of highlighted, this question's highlighted everything I've been saying. Wendy, I'm a biochemist, and if I got cancer, I wouldn't even worry about my pathways. I'd be trying to shut it down every which way I could. And you can overthink this. And I think that does your head in. I'm really sorry. Perhaps I'm being rude. I don't mean to be rude at all. If you look at this, you are worried that your glucose pathways aren't being shut down. You've been on metformin. Okay, switch. Sometimes cancer cells with drugs or anything do get used to it. It stops working. Switch to berberine for a while. Do berberine for a while and go back to metformin if you want to. So switch. I'm not saying it's going to do the trick, but I think it could well do the trick. You're worried about having more circulating cancer stem cells. Maybe that's the doxycycline. Maybe the doxycycline has done its job. Maybe you needed to use berberine or intravenous vitamin C afterwards to finish the job off, a la Lasanti. Have I switched from glucose to glutamine? All right, let me explain glutamine. This is a fascinating subject to me, right? Why? Because I just spent 3.5 days of my life with Thomas Seyfried, the ketogenic diet king of America, okay? Boston College professor. And he wants to shut down my glutamine, if I've got cancer, by giving me 8% of my calories from protein. And as I said to him, I've got a real problem with that because you're doing it to shut my glutamine down, but it's in all my muscles. 25% is in my brain. How are you going to shut my glutamine down without killing me? And anyway, as every 18-year-old kid knows doing biology, it's a non-essential amino acid. So if you shut it down successfully somehow, I'm going to make it in my body, glutamine. So I'm always going to have glutamine, the amino acid. I mean, he said, in all honesty, he said, well, Chris, I admit we've still got a few flaws to iron out in the ketogenic diet. So praise to him for openly admitting that. Now, glutamate is the fuel. Glutamate is produced out of glucose as a reserve. It's also produced out of folic acid, but the big source of glutamate is glutamine. Now, glutamine converts to glutamate using an enzyme, glutaminase. And when we deal with prostate cancer, that's what we attack. Glutaminase is, well, let's put it this way. Prostate cancer is driven by glutamate and fat. Not just my theory. Charles Myers says it's all about fat, and fat, prostate cancer. It doesn't really use sugar, although, berberines are useful adjunct to what we do. And glutamate is such a driver of prostate cancer. Would you believe there's clear research that you don't need to send people for a biopsy to get a Gleason score? You can predict their Gleason score from their glutamate level. Okay, so I'll rest my case. The things we use with prostate cancer, where there's research, holy basil, ursolic acid, lycopene, turmeric, resveratrol, EGCG, those sorts of things. Guess what they do? They block glutaminase. Now, go the other extreme. I've told you I'm not madly keen on doxycycline because it mucks up the gut. They're using it to stop cancer stem cells. Those same things, azelaic acid, lycopene, turmeric, resveratrol, EGCG, plus things like ashwagandha and vitamin D, for example, attack cancer stem cells. So when we build a package, Wendy, everything we do is trying to shut down your feeding and your spreading of your cancer cell, because we're actually attacking the cancer stem cells at the same time, and we're actually attacking glutaminase at the same time, and so on. Are we always successful? No, we're not. But I'm going to come back to today's agenda, off-label drugs. Okay, I think it's really important to kind of recap. Number one, Care Oncology do a very specific job, and their 4 drugs do that job pretty well. Okay, we'll use something else, but their drugs will do the job. Big tick. Jane McClellan, excellent book. She's, you know, told the world her story and how she beat a terminal cancer. Tick. Okay, then I move on a bit. People beat themselves up about off-label drugs. Most doctors don't know how to use them. As I said earlier on, do not try this at home. It's dangerous. You could actually use something that has a big side effect in your body. And at the moment, most ordinary doctors couldn't possibly tell you to use propranolol or dipyridamole because they don't know enough about it and how it might affect this person or that person. So my tuppence worth is always, if you're going to build or want to build an off-label drug protocol, it's because, number one, you're having some drugs and you want them all to work much, much better. Number two, you just want to stop it feeding and you're going to do lots of other things. Or number three, you're almost at a last resort and you want to try something else. But if you do that, I would still, yes, I think it's a great thing to do, stop it feeding, stop it spreading, still do other things. So I'm not against off-label drugs. I'm totally for them. It saves us 10 years while we go looking for another antifungal that actually might make drugs work longer. Saves us 10 years. And this is why the drugs companies don't like this area. They criticize it and whatever, and put skeptics onto people who deal in off-label drugs. So my bottom line is there is definitely mileage in what Care Oncology is doing. There's definitely mileage in some of these other drugs, but you need to go to a professional to put it together for you. It's not something, I'm sorry, it's not something, this is my belief, you can do on Facebook. You can't go and look up a file on Facebook and see that because Fred blogs beat his colorectal cancer using 5 off-label drugs, it'll work for you. The conditions are completely different. It's dangerous. Okay, we don't have enough research.
Chris, I've got to say, I've known you for over 20 years, and I know it all started at Oxford with a biochemistry degree, and thank goodness. And I know the amount of time that you spend, 20, 30 plus hours a week on updating research and researching what's out there and researching the research. And I just, all I can ever say is, you know, if I, God forbid, had a cancer, I would put my total faith and trust in you, because I just don't know anybody who has covered the spectrum in the way that you have. And on behalf of everybody, I thank you for it. And sharing it on these shows is just incredible.
Yeah, well, it's kind of you to say that. I just, you know, we were having this sort of debate online the other week. I can't remember who was involved, but, you know, someone said to me, how many terminal cancer patients have you still got alive today? And when you think, actually, the first 6 people I ever helped 18 years ago, still alive today. I just think it's not rocket science. You know, I know I keep saying it today, you just have to shut the doors. You have to understand from the biochemistry how many doors prostate cancer could run through, how many doors lung cancer could run through. and just shut them. You have to do your homework. I mean, I'll give you a little example. I opened the speech in Australia when I went round, talking about estrogen and chemical estrogen, xenoestrogens. And one of my things was, everybody knows about breast cancer, prostate cancer. I'd hate to get lung cancer. And people will say, up, what's that about? Would you believe there's research from Canada and somewhere else, I can't remember. And it shows quite clearly the biggest growth area in non-small cell lung cancer is in younger women who've never been near a cigarette. And they nearly always have EGFR, epithelial growth factor. There's research, because the Canadians in the research said they thought, in the first instance, they thought it was to do with toluene, nail polishes, perfumes, xenoestrogens, and so on. There is research that shows that if you block estrogen when taking something like Avastin, it makes Avastin work better. Now, I'm not talking about one study. I'm talking about 5 or 6 that I could find in about 10 minutes. Who does it? We do it. Little old lady. I can't, we had on the show. Lovely old lady. She had her drugs. We blocked her estrogen at the same time she took her drugs. It's there in black and white. You just got to do your homework. Hey ho, get me 25 new researchers, please.
Well, that's my next point. I'm going to put my chairman's CA hat on again now. We charge for these shows. It's £10 the first time somebody registers. After that, they've become a member. It's only £5 a show, for goodness sake. And every single penny goes to CANCERactive. Why? Because we thrive on donations. It's the only way we can actually survive. But apart from all the other overheads that we have of the website and magazines, which we can't produce at the moment because of COVID, they can't go into places. But the biggest thing is, you need help and support with research. The people out there need you to have the help and support with research. And we need to be raising just probably 125 to 130,000 a year just to provide 4, 5, 6 researchers. And I would say that people that donate, thank you very, very much. People who become a member of CANCERactive at £3 a month or £60 a year have no idea of the good that they actually do and the good that they help you do, mate. And, this is a chat between the two of us, which is recorded and goes out to the world, but I thoroughly enjoyed it. And I know the work that you do. And all I can say is thank you, and look forward to the next show in 4 weeks' time, where we're going to be covering what, Chris?
And the next big show is Julian Kenyon and me. And we are going to be talking microbiome, but his latest game is fecal transplants. So we've just had loads of new research in about the microbiome, how it totally boosts your immune system or puts it down and so on. And we'll cover a bit of that, and then we'll talk about fecal transplants and so on. Because fecal transplants ultimately could be the game changer, because at the moment they're only really allowed for IBS and Clostridium difficile and so on. But what if once you had your drugs, you could do a fecal transplant and put yourself back to normal, how you should have been before cancer?
Yeah, wow. Okay, great. Don, I'm really, really going to look forward to that one. Chris, I'm going to say goodbye on behalf of everybody. Thanks ever so much, and really, really appreciate all the time you put in. Bye now.
All right, thank you, everybody. I'd like to thank everybody for listening, as always. It's great. Nice talking to you, Larry.